Participants who have joined, I am sharing a link of registration here. This registration is for certificates, because we are seeing that most of the doctors are complaining that they have not received the certificates. Hence, we want to make a Google form through which all the registered doctors will get the certificates for sure. I hope all of you have received the Google form. It can be found in the chat section, chat box. Doctor?
Yes, madam.
Like just in case ನೀವು ಟ್ರಾವೆಲಿಂಗ್ ಏನಾದ್ರು ಇದ್ದೀರಾ ಡಾಕ್ಟರ್? ಅಥವಾ ಯಾವ್ದಾದ್ರು ವಿಂಡೋಸ್ ಏನಾದ್ರು ಓಪನ್ ಇದೆಯಾ? ಅಂದ್ರೆ ಜಸ್ಟ್ ಸಮ್ ಏರಿ ಸೌಂಡ್ ಬರ್ತಾ ಇದೆ ಅಂತ. Yeah, doctor, this is much better. Yeah, this is much better.
Okay.
Okay. Doctor, namdu session 2:30 shuru agbeku. So we will wait till 2:30 or 2:35 until we have a good number of participants. Nantra shuru ಮಾಡೋದು doctor. So I think as of now, technical issues as such ಏನು ಇಲ್ಲ. Okay. Doctor, nimdu have you kept your slides open now or
ಶೇರಿಂಗ್?
ಯಾಕಂದ್ರೆ ನಂಗೆ ಕಾಣಿಸ್ತಾ ಇಲ್ಲ ಇಲ್ಲಿ ಸ್ಕ್ರೀನ್ ಮೇಲೆ, ಹಾಗಾಗಿ ಕೇಳಿದೆ.
ಕಾಣಿಸ್ತಾ ಇದೆಯಲ್ವಾ?
ನನಗೆ ಕಾಣಿಸ್ತಾ ಇಲ್ಲ. Participants, if any of you are able to see the presentation, please drop a yes message in the chat box, or at least you can give thumbs up.
ಇದು ಫಸ್ಟ್ ಸ್ಲೈಡ್ ಅದು ಕಾಣಿಸ್ತಾ ಇದೆಯಲ್ಲ ಮೇಡಮ್?
ಇಲ್ಲ ಡಾಕ್ಟರ್, ನನಗೆ ಫುಲ್ ಬ್ಲಾಂಕ್ ಕಾಣಿಸ್ತಾ ಇದೆ.
ಬ್ಲಾಂಕ್ ಇದೆಯಾ?
ಮೂಮೆಂಟ್. ಯಾ, ಈಗ ಐ ಆಮ್ ಏಬಲ್ ಟು ಸಿ.
ಇಟ್ಸ್ ಓಕೆ.
ಇಲ್ಲ, ನೀವು ಪ್ರಾಬ್ಲಿ ಪ್ರೆಸೆಂಟೇಷನ್ ಹೋಗಿದ ತಕ್ಷಣ ಅದು ಸ್ಕ್ರೀನ್ ಹೋಗ್ತಾ ಇದೆ. ನೋಡಿ, ಈಗ ಐ ಆಮ್ ಏಬಲ್ ಟು ಸಿ. ಈಗ ಕಾಣಿಸ್ತದೆ. ಇದು ಸ್ವಲ್ಪ ಎನ್ಲಾರ್ಜ್ ಮಾಡಿ ಡಾಕ್ಟರ್, ನೋಡೋಣ. ಎನ್ಲಾರ್ಜ್ ಮಾಡಿದ್ರೆ ವಿ ಆರ್ ನಾಟ್ ಏಬಲ್ ಟು ಸಿ. ದಿಸ್ ಇಸ್ ಸಮಥಿಂಗ್ ವಿ ಆರ್ ಏಬಲ್ ಟು ಸಿ.
ಬಟ್ ಅದು ಎನ್ಲಾರ್ಜ್ ಆದ್ರೆ ಬರ್ತಾ ಇಲ್ಲ ಅಲ್ವಾ?
ಎನ್ಲಾರ್ಜ್ ಆದ್ರೆ ಬರ್ತಾ ಇಲ್ಲ.
ಇದು ಪಿಪಿಟಿ ನಿಮಗೆ ಶೇರ್ ಮಾಡಿದ್ರೆ ಅಲ್ಲಿಂದ ಮಾಡ್ಲಿಕ್ಕೆ ಆಗತ್ತಾ?
PPT, yeah, I guess doctor, I must be able to do it.
ಯಾಕಂದ್ರೆ
ಡಾಕ್ಟರ್, ಇನ್ನೊಂದು ಆಪ್ಷನ್, ನೀವು ಅದು ಫೈಲ್ ಮೇಲೆ ಹೋಗ್ಬಿಟ್ಟು ಓಪನ್ ವಿತ್ ಓಲ್ಡರ್ ವರ್ಷನ್ ಆಫ್ ಇದೇನಾದ್ರು ಇದೆಯಾ? 2016 MS 2016 ಏನಾದ್ರು ಇದೆಯಾ?
ಅಲ್ಲ, ಇದು WPS ಅಲ್ವಾ, ಎಲ್ಲದಕ್ಕೂ ಅಪ್ಲೈ ಆಗುತ್ತೆ ಮೇಡಮ್. ಇದು ಓಲ್ಡ್ ನ್ಯೂ ಎಲ್ಲದಕ್ಕೂ ಬರುತ್ತೆ.
ಅಲ್ಲಲ್ಲ, ಸ್ಪೆಸಿಫಿಕಲಿ ಓಲ್ಡ್ ಅಲ್ಲಿ ಓಪನ್ ಮಾಡಿ ಒಂದ್ಸತಿ ನೋಡಿ ಅಂತ ಅಷ್ಟೇ.
ಓಕೆ ಮೇಡಮ್, ಓಕೆ.
ಇಲ್ಲಾಂದ್ರೆ ಡಾಕ್ಟರ್, ನಾನು ನಿಮ್ಗೆ ವಾಟ್ಸ್ಆಪ್ ಮಾಡ್ತೀನಿ, ನೀವು ನನಗೆ ಇಮೇಲ್ ಅಲ್ಲಿ ಕಳಿಸಿ ಕೊಡಿ. ಸೊ ಐ ವಿಲ್ ಓನ್ಲಿ ಟ್ರೈ ಟು ಶೇರ್ ಇಟ್ ಹಿಯರ್.
ಎಸ್ ಮೇಡಮ್, ಎಸ್ ಮೇಡಮ್.
ಇಫ್ ಯು ಆರ್ ಓಕೆ.
ಇಲ್ಲಿವರೆಗೂ ಬರುತ್ತಲ್ವಾ?
ಇಲ್ಲಿವರೆಗೂ ಬರ್ತದೆ ಡಾಕ್ಟರ್.
ಇದಾದ ತಕ್ಷಣ ಹೋಗ್ಬಿಡುತ್ತೆ.
ಹೌದು ಡಾಕ್ಟರ್.
ಓಕೆ. ಈಗ ಸ್ಲೈಡ್ ಶೋ ಇದೇನಾದ್ರೂ ಕಾಣಿಸುತ್ತಾ? ಈಗ ಏನಿಲ್ಲ.
ಇಲ್ಲ doctor, the screen is completely blank.
Blank. ನಿಮಗೆ ವಾಟ್ಸ್ಆಪ್ ಮಾಡ್ತಿದ್ದೀನಿ ನೋಡಿ.
ವಾಟ್ಸ್ಆಪ್ ಮಾಡ್ತಾ ಇದ್ದೀರಾ?
ಹಾ,
ಓಕೆ ಓಕೆ ಡಾಕ್ಟರ್, ಮಾಡಿ.
ಟ್ರೈ ಮಾಡಿ ಮೇಡಮ್, ಅಕಸ್ಮಾತ್ ಅಲ್ಲಿ
Yeah,
ಏನಾದ್ರು
sure. Okay, doctor.
ಫೈಲ್.
ಅಲ್ಲಿ ಮೇಲ್ ಹೋಯ್ತು ಡಾಕ್ಟರ್, ಅಲ್ಲಿದೆ ನೋಡಿ, ರೀಸೆಂಟ್ ಚಾಟ್ಸ್ ಅಲ್ಲಿ ಫಸ್ಟ್ ಬಂದಿದೆ.
ಕಳಿಸಿದ್ದೀನಿ ನೋಡಿ.
ಓಕೆ ಡಾಕ್ಟರ್. ಡಾಕ್ಟರ್, ನಾನು ಡೌನ್ಲೋಡ್ ಮಾಡ್ಕೊಳ್ತಾ ಇದ್ದೀನಿ. ಸ್ಕ್ರೀನ್ ಬರ್ತಿಲ್ಲ ಅಲ್ಲ? ಯಾ ನಾನು ಐ ಆಮ್ ಟ್ರೈಂಗ್ ಟು ಪ್ರೆಸೆಂಟ್ ಫ್ರಮ್ ಮೈ ಎಂಡ್. ಓಕೆ ಡಾಕ್ಟರ್, ನೀವು ಸ್ಕ್ರೀನ್ ಶೇರ್ ಆಫ್ ಮಾಡಿ ಡಾಕ್ಟರ್. ಐ ವಿಲ್ ಟ್ರೈ ಫ್ರಮ್ ಮೈ ಎಂಡ್.
ಎಸ್ ಮೇಡಮ್.
ಡಾಕ್ಟರ್, ಐ ಗೆಸ್ ಈಗ ಸ್ಕ್ರೀನ್ ವಿಸಿಬಲ್ ಇದೆ ಅಲ್ಲ?
ಎಸ್ ಮೇಡಮ್. ಅದು ಎನ್ಲಾರ್ಜ್ ಮಾಡಬೇಕು
ಈಗ.
ಓಕೆ. ಎಸ್.
Okay, doctor, I think we have enough participants. So shall we start the session, doctor?
Yes, madam.
Okay. Dr. Mr. Satish, I will start with the session. So could you please admit the people who is trying to join the session?
Yeah,
Satish?
sure.
Yeah, please. Once my introduction goes, then I will allow the participants. Until then, you please allow the participants whenever there is a request to join the session. Okay. So, good evening, good afternoon, everyone. Very warm welcome to Insight, our monthly continued Ayurvedic education series, thoughtfully created for clinicians and practitioners who believe that learning never truly ends. As you all know, I'm your Dr. Usha, the host for the session, and I'm genuinely delighted to see you all. Whether you're joining Insight for the first time or returning for another session, welcome. Insight was born for a simple belief that the best Ayurvedic practitioners are those who never stop questioning, never stop learning, and never stop growing. Today, we come together in that spirit. What you will take away from today's session is not just knowledge, it is clinical wisdom, practical insights, and approaches that have genuinely transformed patient outcomes. About our sponsoring brands, Ayur Central, as you all know, Ayur Central began as a single clinic in Archanagar, Bangalore, and has now grown into India's largest Ayurvedic clinic chain, and network of around 72 clinics across Karnataka by 120 plus dedicated doctors. At Ayur Central, our purpose has remained unchanged to make genuine, trustworthy Ayurveda accessible to every patient through both our physical clinics and our growing digital presence. Ayurveda One is our sister concern and the manufacturing heart of our ecosystem. Every formulation is doctor designed, research driven, and crafted to the highest quality standards. Because we believe that what a doctor prescribes must deliver real, measurable results. Our vision is to place Ayurveda One products in the hands of every quality conscious practitioner across India, bridging classical Ayurvedic wisdom with modern clinical precision. Quick announcements for today. Our YouTube channel link has been shared in the chat. Do subscribe to stay updated for future sessions. To ensure your participation certificate reaches you smoothly and without delay, we are now introducing a simple Google form. The link will be shared in chat box shortly. Kindly take a moment to fill in your details. It will take less than a minute and it guarantees your certificate lands exactly where it should be. Thank you for your patience and we promise no more missing certificates. Also, we would like to have a feedback from you about our sessions to do better than what we are doing. Today's session is approximately 1 hour long. Feel free to type your questions in the chat at any time. We will address them all during the question and answer session. For any technical difficulties, our support team is available in the chat. Now, without further ado, let's welcome our speaker for the day, Dr. Gopala Krishna. It's our privilege to introduce today's esteemed speaker, Dr. Gopala Krishna G, a distinguished academician and clinician in the field of Ayurveda. Dr. Gopal Krishna completed his BA/MS from Taranath Government Ayurvedic Medical College, Ballari in the year 1998, followed by his MD in Kaya Chikitsa from Government Ayurvedic Medical College, Mysore in 2002. With a strong foundation in classical Ayurveda and clinical medicine, he has dedicated over 2 decades to the practice and teaching of Ayurvedic science. He is currently serving as professor and head of the Department of Kaya Chikitsa at Sri Sri College of Ayurvedic Research and Sciences, where he plays a pivotal role in mentoring postgraduate scholars and shaping the next generation of Ayurvedic physicians. In addition to his academic contributions, Dr. Gopal Krishna has been a consultant at Upadhyaya Ayurveda Pharma for over 18 years, actively involved in clinical practice and therapeutic applications of Ayurvedic formulations. His clinical expertise lies in the management of chronic and lifestyle disorders, where he is known for delivering consistent and result-oriented outcomes through classical Ayurvedic approaches. He has authored and presented numerous research papers and has been invited as a guest speaker at various academic and clinical platforms, sharing his insights on general medicine and holistic patient care. Dr. Gopal Krishna is widely respected for his clinical acumen, teaching excellence, and ability to bridge classical Ayurvedic wisdom with contemporary healthcare needs. We are truly honored to have him with us today to share his valuable perspectives. Dr. Gopal Krishna, a very warm welcome to you. The session
Thank
is
you,
over
madam.
to you, sir.
Thank you, madam, for your wide introduction about me. Thank you once again. So, good afternoon, everyone, for this session. Respected dignitaries, doctors. Am I audible, madam?
Yes, doctor, you are audible.
So, respected dignitaries, their faculty, and various doctors, faculty members, and all for this session. So, before starting our presentation, I would like to thank Ayurveda One for giving me this opportunity. So, basically, about today, we will just have a discussion, understanding about this CKD, chronic kidney disease. So, this chronic kidney disease is burning issue nowadays in the modern signs, as they doesn't have any good medicine, the one which can save the kidney. So this is one major issue. Either they depend on the risk factors, or they directly enter into the dialysis, or lastly they are now planning to go for renal transplantation. So there is no any particular specific medicine, the one which can save the kidney. So and this is the situation, present situation in the modern science. But what Ayurveda says regarding this condition, we will be able to understand in this 1 hour. So first of all, when a patient comes with pedal edema, unilateral pedal edema, one leg is swollen. So usually the diagnosis go with local reason. So like it may be venous insufficiency or lymphatic insufficiency and all. So local reasons are considered and local measures are taken care, and the problem is solved. But whenever a patient come with bilateral pedal edema, bilateral onset and bilateral presentation, bilaterally symmetrical onset and bilaterally symmetrical presentation of pedal edema, we will have to think about three major systemic organs. One is the kidney, one is the liver, one is the cardia. So amongst them, one organ, important organ, which can contribute for the bilateral pedal edema, symmetrical onset and symmetrical presentation of pedal edema. So the major organ comes into picture is the kidney. So if there is a kidney dysfunction, kidney failure, so nowadays chronic kidney disease, the person may come with this type of presentation. So with this introduction, we'll enter into the kidney. So how the normal kidney looks like, you can just see in the slide. Renal artery collects the blood from the left ventricle, and it is entering into the general the nephrons, wherein nephrons will decide what to be filtered and what to be sent into the loops, especially the cells, RBCs, WBCs, platelets, and even the protein components. And all these things are filtered and they are sent back into efferent blood vessels, and from there again the venous blood, renal vein, will collect that blood and enter into general circulation. So the unwanted materials, for example, biological metabolic waste products, like it may be urea, creatinine and all, they are left into the urine, and it is collected, it is collected into the collecting tubule. From there, it is expelled through the bladder as urine. So this is what usually a healthy kidney does. But not only the functions of kidney limit here only. Next slide, please. So here we have other major functions pertaining to kidney also. Kidney. The major functions like removing the metabolic waste products and balancing overall homeostasis and hemostasis of the individual. So overall 1500 ml of urine output should be regulated by the kidney only. And balancing the minerals, balancing the chemicals, and especially the blood pressure, renal, especially renin, angiotensin, aldosterone system, RAAS system, will control overall blood pressure. This we call it as secondary hypertension. If the kidney fails in its activity, then definitely the person can suffer from hypertension. This is called as secondary hypertension. Then third one, especially RBC production. Overall, like erythropoietin hormone, the one which comes from juxtaglomerular apparatus, will govern the overall erythropoiesis, and that erythropoiesis is totally maintained by this erythropoietin hormone. So that's why if kidney is under trouble, then the erythropoietin hormone secretion is inhibited and overall erythropoiesis won't happen. So the person has to suffer from anemia. So this is one thing. And next, even for a healthy bone, especially the vitamin D, the one which comes from the ultraviolet rays through the skin, is activated in the kidney, and that helps in absorption of calcium and to maintain the bone mineralization. that is also maintained by the kidney. So many functions are there, so many importances are there pertaining to the kidney. So if this kidney goes wrong, then all these aspects have to be suffered. So next slide, please. So what is CKD? It is not a condition like we got a fever, took medicine for 1 week, 10 days, got cured once for all. It is not that condition. It is progressive, irreversible loss of kidney function. That's why in the modern science, they say there is no any medicine for this condition. Whatever the risk factors are there, whatever the causative factors are there, we will have to tackle those causative factors and see that the disease process won't go further. If it crosses 4 mg or 5 mg per dl, especially the creatinine and all the waste products in the blood, so definitely the person may land up into dialysis or later into renal transplantation. So when once the person loses his kidney's normal function, glomerular filtration will be affected. There will be inflammation going on in the glomerulus, and that leads to lack of filtration, especially as we were discussing, all the RBC, WBC, platelets, proteins and all would have been filtered properly. That filter function is lost. Even the water, especially the fluid content, plasma content, that is also lost. That balance is also lost. And major, especially the urea and creatinine, the metabolic waste products, they are not filtered and rather they are sent back into the bloodstream. So there, the person may land up into azotemia. Next slide, please. So these are the major culprits. Diabetic person, anyhow, common prognostic value, especially common complication of diabetes mellitus leading to diabetic nephropathy, hypertensive nephrosclerosis, autoimmune glomerulonephritis, IgA nephropathy, polycystic kidney disease, or sometimes obstructive uropathy. So for example, a big calculus coming and just blocking the renal pelvis can lead to obstructive uropathy. Some toxic drugs, especially nephrotoxic drugs. In the modern science, there is a list of drugs which are nephrotoxic. For example, sulfonamides or streptomycin, or especially this aminoglycosides and all, they are all nephrotoxic. Again, they can damage the kidney function. Finally, the ultrafiltrate of the kidney, glomerular filtration, is getting affected. So there will be discrepancy, there won't be proper filtration, so that leads to edema. Next slide. So how the pathophysiology goes? Because of all these etiological factors, there will be progressive nephron damage. First, initially, it will be doing its normal activity, like filtering, erythropoiesis, everything, all the functions it would have been carried. But at one junction, it will lose its original function. Rather, it will start showing inflammatory response that leads to acute glomerulonephritis. And when once its threshold is crossed, the nephrons have to die, and that will be like a permanent damage for the kidney. So there, the glomerular filtration rate will start declining down. So the toxins will be retaining there only in the blood, and that leads to azotemia. Fluid and electrolyte imbalance happen because of the same issue. RAAS activation happen. So initially, the person was suffering from hypertension, that is leading to nephrosclerosis. Now, because of that nephrosclerosis, again in turn the person suffers from hypertension, that leads to secondary hypertension. And as we were discussing, erythropoietin hormone secretion is also inhibited, that leads to again severe anemia. Vitamin D activation is also lost, so the person will be suffering from renal osteodystrophy. So these pathological changes will be happening when once the kidney loses its original function. So then later we have the stages. Chronic kidney disease, based on the glomerular filtration rate, it is staged like stage 1, stage 2, stage 3, stage 4, stage 5. Usually stage 5 is considered as end stage renal disease. So wherein there is no use of this existing kidney, so a person has to go for renal transplant only. So this is the advanced stage of CKD. So one, we should not forget about these stages, at what stage the person has come to us, whether the stage is along which stage, the etiological factor. So both the things we will have to merge, and we can prepare a proper protocol, treatment plan for addressing this issue. So if it is more than or equal to 90 ml per minute per 1.73 meter square, it is considered as like a normal. Provided if a patient is having some risk factors already, then it can be taken as stage 1. If it comes between 60 to 80, 89, then it is called as mild. Then 30 to 59, moderate. 15 to 29, severe. If it crosses 50, then it can lead to acute on chronic kidney disease or acute on chronic renal failure. The person may get compromised with the kidney function totally. Then it will be like useless. So the staging goes like this. Slide. The stages go like this, the same thing what I was explaining. So how to mark the symptoms right now? See, for example, lethargy. Because the person has lost so much hemoglobin, first of all, hemoglobin is not properly formed. So oxyhemoglobin and carboxyhemoglobin activity is lost. So the person will be always lethargic. So this can be expected. Then nausea and vomiting because of the toxins which are now retaining, for example, urea and creatinine. Because of those two, so they are circulating in the blood, so they can cross the blood-brain barrier. They can influence the chemoreceptor trigger zone. So the person will get nausea and vomiting. And hypertension, again, the same thing. Because of secondary, there will be hypertension. Initially, there will be retention of especially anuria, but later on, when it progresses to chronic kidney disease, the person will have more and more urination, even nocturnal urination also. So loss of appetite also is expected. As we were seeing, especially the leg swelling, bilateral pedal edema, symmetrical onset and symmetrical presentation, that can be expected here. And loss of weight because of generalized weakness. So these features can be expected in CKD in the early stages of CKD. But as the disease progresses, there will be oliguria, then severe edema, generalized edema. Initially, we were observing, especially one is regarding the loss of albumin, and because of gravity. Both the reasons, there will be pedal edema and as well as periorbital edema also. And that periorbital edema, as it starts descending down, there may be possibility of pleural effusion, so that can create the shortness of breath, nausea and vomiting. And because of the toxins which are circulating all over the body, so there will be generalized pruritus. So a person who is coming with generalized pruritus, one index of suspicion, like there may be possibility of high creatinine, go for the risk factors, causative factors, and go for assessment of urea and creatinine. At one junction, we may get a clue that the person is suffering from chronic kidney disease. And here and there, bony pains because of vitamin D deactivation and bone mineralization is not properly happening. So because of that reason, there will be severe body pains and bony pain. Because of renal osteodystrophy, the person may be suffering from osteopenia or osteoporosis. And unexplained hypertension, especially in young adults and all, one has to think about renal pathology. So these may be the later findings which we come across in CKD. Next slide, please. No. So these are the investigations what we usually expect in chronic kidney disease. When once a person is coming with above mentioned presentation, we will have to think of these things. For example, a simple anemic patient. So we will have to screen out what type of anemia the person is suffering from, whether megaloblastic type, macrocytic hypochromic or microcytic hypochromic or normal blood picture and all. So we will get an idea that, okay, where may be the problem, where may be the hidden pathology pertaining to this anemia. One reason can be because of CKD. So then we will have to go for serum creatinine and blood urea. Definitely these are the toxins which are elevated in the blood because they are not properly expelled out. As we were analyzing the glomerular filtration estimation, That also we will have to go for. One test is there, like as soon as the person is confirmed that he is a known case of diabetes mellitus, or since so many months HbA1c is not properly coming under control. So then one simple test what we will have to address is microalbuminuria 24 hours. If we address that issue and take care that microalbuminuria 24 hours is very well maintained, then we can altogether avoid the ongoing process of CKD. So that can be avoided, provided it has to be detected very early in the lifespan of the, especially the diabetes mellitus or hypertension, whatever the disease process is, whatever the causative factors are there. So then that's why urine for protein, because protein is very much essential for our body. If it is not properly filtered at the glomerulus and it is not sent back to the efferent blood vessel, there is a leakage of protein. So leaky kidney. So that leads to hypoproteinemia in the blood, whereas proteinuria in the urine. Electrolytes also the same thing. And when we go for ultrasound, there is because of shrinkage of the nephrons, there is a possibility of shrinkage of kidney. If the bulk of nephrons comes down, there will be even shrinkage of the kidney. So that is contributed because of the nephrons only. As the nephron size is coming down, definitely there will be shrinkage in the kidney also. And CBC, finally, we have to go for HB percentage and peripheral blood picture to analyze what type of anemia the person suffering from. So that will give an idea about what type of anemia the person is suffering from. And finally, we can land up that this person is suffering from CKD, and these varieties of investigations are pointing out towards CKD only. So easily we can differentiate from other possibilities. So for example, LFT coming within range, and 2D echo, two-dimensional echocardiogram, M-mode cardiogram, or Doppler scan. So that is coming normal, like right heart issue, there is no any issue. Right atrium, right ventricle pumping, everything, ejection fraction, everything is fine. So that is addressed separately. So we can differentiate that it is only because all these edema, all these issues are only because of CKD. So nothing else. That can be differentiated by going through these common investigations. Next slide. So suppose if this CKD is not properly addressed, so the person will be landing up into anemia, hyperkalemia, especially anemia, severe anemia. You see here, if we are not able to understand what is this type of anemia, and if you just go on giving iron supplements and all, is of no use. Anemia, we will have to understand what type of anemia the person is suffering from and what exactly is deficient, and that has to be replaced. Then only this anemia can be rectified. Even the same hyperkalemia, potassium ions are also again filtered back. So that will go back into the general circulation and can influence the cardiac rhythm. So it can lead to severe fatal cardiac arrhythmias. So that also has to be taken care as early as possible, like potassium, not sparing the diuretics, potassium should be expelled out from the body. Otherwise, the person may land up into metabolic acidosis. So renal osteodystrophy, again the same thing, vitamin D. If it is not supplemented properly and calcium supplements are not properly supplemented, the person will land up into valgus deformities or severe osteopenia or osteoporosis. As we were discussing, cardiovascular, if the hypertension especially is not taken care properly, finally the person will land up into cardiovascular complications. There may be possibility of fluid overload because kidney is unable to filter 1500 ml urine output we are expecting, but there is anuria or oliguria, again it is returning back. So finally the person will be landing up into either uremia or azotemia. So these may be the complications. That's why first of all we will have to identify which organ is involved in the disease process based on the presentation, rule out cardia, rule out liver, and finally come to a conclusion that it is because all these things are happening because of the chronic kidney disease, and address each one separately so that we can avoid all these complications. Next slide. So mainly the treatment aims at causing the uh, treating the cause, especially if a person is diabetic and diabetic nephropathy. Until and unless you are not treating the diabetes mellitus and you are not bringing the HbA1c to the normal range, how far you go for any medicine which can improve the kidney function, it's of no use. So that's why, first of all, we will have to identify what is the causative factor behind this CKD. First, we'll have to address that issue, understand and address that issue properly, then half work is done. Later, we have our own protocol which can address these issues. So then control diabetes mellitus, control hypertension, so like keeping the blood pressure 200 by 120, going on giving Punarnavadi preparations and all of no use. So that's why we will have to plan for such a medicine which can improve the kidney function, which can address especially all the risk factors, then come back to ACE inhibitors or diuretics or erythropoietin hormone injection, phosphate binders, and vitamin D3. This is what exactly the modern people say about the management of CKD. So nowhere there is any concept pertaining to improving the kidney function at the nephrons level, reducing the inflammation at the nephron level, protecting the ultrafiltrate at the nephron level. So there is no any say pertaining to that aspect in the modern science. Just address the causative factor and go for diuresis, erythropoietin hormone because that is deficient, replace that one. Vitamin D is deficient, replace that one. Phosphates deficiency, replace that one. Just see that bone density is very well maintained and wait till we get sufficient serum creatinine level. If it crosses 4 or 5 mg per dl, prepare the patient for dialysis. So this is what exactly it is going on in the modern science. Next slide, please. So overall, like diet modification, lifestyle correction, simple diet modification. Diet modification and lifestyle also depend on the causative factor only. So suppose a diabetic patient is there, so then diabetic diet has to be monitored properly. If a patient is suffering from hypertension, accordingly it has to be planned, salt resistant diet. And especially proteins are lost from the body. So if you overload protein, again there may be damage to the nephrons based on this overload of protein. So that's why we'll have to avoid excess protein consumption. Potassium sparing, especially potassium binders should be used here. Fluid restriction, again there may be overload over the kidney until you are not rectifying the basic pathology pertaining to the kidney. The nephrons are not addressed. Till that, better not to overload with fluid also. Mild to moderate exercise just to maintain the fitness. And if a person is smoking and all, there may be possibility of nephrosclerosis. So better to avoid or quit the smoking. Next slide. So this is what usually in the modern science they are practicing, either hemodialysis or peritoneal dialysis or lastly renal transplantation. Because one thing they lack in this concept, especially a medicine which goes at the level of kidney, nephrons, can filter the ultrafiltrate, can reduce the inflammation process, Shodhana and all. So that concept is not there in the modern science. So they are directly depend on the treatment of the causative factors and treat the symptoms and prepare the patient for dialysis or renal transplantation. So prognosis. Again, I told it is not a case of a simple fever got cured once for all. Again, there won't be any relapse. So once for all, it got cured. It all depends on the risk factors, the causative factors. As the causative factors are all progressive in nature, so the disease is also progressive in nature. And that's why early detection, especially microalbuminuria, early detection if we does and see that early detection and early treatment is done for the major primary disease, then secondary CKD can be arrested there only and can be treated very well. And at least that ongoing process of degeneration, sclerosis can be arrested there only. And in the advanced stages and all, the person may land up into dialysis or renal transplantation. So what Ayurveda says regarding this condition? One common question, like, do you have any concept in Ayurveda dealing with kidney? Because we come across with Vrukka, Vapavahana, all those things in some srotasas and all. But how to understand this concept, especially CKD, through Ayurveda? Many thesis works, research works, and all have been done based on Kaphaja Shotha in understanding CKD. That's why CKD can be understood, can be taken, can be correlated with that of Kaphaja Shotha. How we will just understand. So of course, common Nidanas and all, what Ayurveda says about the Shotha. Here Shotha, Vrana Shotha, Shofa. Vrana Shotha is something different. Shotha is different. Shotha, transudate fluid accumulation in the body. Whereas Vrana Shotha, that is exudation, the one which is happening in the body. Wherein we can expect, especially in Vrana Shotha and all, we expect Amavastha, Pachamanavastha and Pakavastha and all. Here there is no question of Amavastha, Pachamana or Pakavastha, as it is transudate fluid. How this Shotha happen? Here we have some of the Ahara Nidanas like Guru, Amla, Katu, Lavana, Pishtana type of food items. Overall, the idea is Ahara Nidana definitely should impact on Avastha, Paka and Agni should get impaired and Ama should get formed. So those are the Nidanas. Then Viharaja Nidana we come across with like Panchakarma Vyapat, Upadrava, Swarupa, of certain diseases like Shwasa, Kasa, Atisara, Pandu. Here as a Pandu is also mentioned as Upadrava. So such conditions can lead to Shotha. Okay, for example, you are in Pandu Roga leading to Shotha, anemia, hypoalbuminemia leading to Shotha. So Udara Roga leading to Shotha. For example, again, hypoalbuminemia and increased portal hypertension leading to Shotha. Jwara leading to Shotha. Wherever there is hypoalbuminemia, hypovolemia, there is a possibility of Shotha formation. So next slide, please. So Vishishta Nidanas, like again, in especially for Kaphaja Shotha in our classics, we come across with like again Ati Sevana of Guru, Madhura, Shita, Snigdha Dravya and all. Then Ati Nidra and Ati Avyayama and all. The person may land up into this type of Shotha. And of course, the causative factors as Nidana, Artakara, Roga, whatever we were dealing in the modern aspect, all those Nidanas can be taken as Nidana, Artakara, Roga for leading to Kaphaja Shotha. Next slide. So overall, like Vana Vata, the one which circulates all over the body, taking Jaliya Dhatu, especially up Dhatu, Mudravaha and Svedavaha Srotas, that gets obstructed because of already vitiated doshas that leads to Vata Prakopa, and rather there is the Sangha and Vimarga Gamana. So all those doshas along with Abdhatus, they are all taken towards the periphery, and there Twak Mamsa Antara, there will be accumulation of this fluid leading to Utseda, leading to Shotha. So but one thing we will have to understand, nowhere we come across with any reference pertaining to Mutravaha Srotas or kidney, Vrukka involving in the disease process. Then how to understand Kaphaja Shotha to that of modern CKD? Next slide shows. Next slide, please. See here, you can just go through the Lakshanas. Third Lakshana, Pandu. As we were discussing in CKD, the person will be suffering from Pandu, anemia. And ninth one, you can just see slow development of swelling and slow subsiding. And 10th Lakshana, pitting edema, which is commonly observed in such type of Shotha, as we were discussing, especially kidney, liver, and cardia. Amongst them, first preference comes with that of kidney disease, especially CKD. So slow development of swelling, slow subsiding, and pitting edema is commonly observed. And along with the patient will be anemic. this anemia won't be there in even liver pathology or cardiac pathology. So that's why commonly Kaphaja Shotha can be considered as CKD. We can correlate to that of CKD. Next slide, please. So, of course, ama formation. That's why one has to plan for Langana and Pachana, and later we will have to plan for Vamana and Virechana. And if the Shotha is available more over the Urdhva Jatragata, then one can plan for Shiro Virechana and Nasya Karma. Other Sharira, we will have to plan for either Vamana or Virechana. Okay. But one thing is, the patient may not be indicated for such type of Shodhana procedures, because as the person is already suffering from chronic kidney disease and the person is suffering from severe anemia, though the disease is indicated for Shodhana procedure, but the patient practically may not be indicated for Shodhana procedure. So at that junction, better to plan for Samshamanam line of treatment. Next slide. So here, one yoga, you can just see Gomutra Haritaki as a Nitya Vilechana drug. This can be adopted to clear up dosha and to clear the channels. Next slide. Next slide. Here we have important Ayurvedic drugs. Punarnava, the one what we were discussing about the CKD, so like at the level of nephrons, anti-inflammatory preparations, and the one which can do like a diuretic property, which can enable to improve the iron absorption, all those properties, especially nephroprotective. What is that nephroprotection? Especially clearing the ultrafiltrate, especially reducing the inflammation at the level of nephrons. That concept itself is considered as rasayana and nephroprotective actions, which can be done by these ekamulikas, especially Punarnava, Gokshura, Varuna, Guduchi, and Shilajit. Next slide. So Shilajit, already proven medication which is rich in fulvic acid, which can improve the renal function. What is that improvement in the renal function? It is just clearing the edema, reducing the inflammation process which is going on at the level of nephrons, and finally the person will have a normal urine output. And at the same time, like some causative factors like uric acid and all can be managed. Even kidney stone, the one post-renal obstructive pathologies, obstructive uropathy, that also can be addressed by using such type of drugs. Shilajit. Next slide. So Punarnava Shotagni, we call this as Shotagni only. How? Because it can filter, it can improve the renal creatinine output, and reducing the inflammation process going on at the nephrons and improving the renal function. So wherever we come across with the word renal, especially nephroprotective, nephrosave, is nothing but reducing the inflammation process at the nephrons. So this concept is lacking in the modern science. So that's why they say like there is no any such medication which can improve the kidney function. But fortunately, we have this type of concept, and we are seeing the results by improving, by seeing the levels, reduction in the creatinine level or urea level, proper control of diabetes mellitus or any other risk factors and all. We are observing the results. Next slide. So Gokshura also the same thing, natural diuretic, nephroprotective, and can help in removing the obstructions, like it may be Ashmari. So Gokshura is also one of the drug of choice. Next. So Varuna, already see whatever the yogas or the ekamulikas, whatever we are seeing here, all are having the research background, studies, and these definitely they can contribute in improving the kidney function. So nephroprotective, diuretic, and anti-inflammatory. Wherever we come across with anti-inflammatory, the inflammation which is going on at the level of nephrons, that is getting reduced, and we are getting the proper ultrafiltrate. So Guduchi, overall immunomodulator, and at the same time nephroprotective, antioxidant, and immunomodulatory. So some of the formulations what we come across, like Chandraprabha Vati, Punarnavadi Kashayam, Gokshuradi Guggulu, Varuna Kashayam. Of course, all such preparations can be adopted in chronic kidney disease patients. So especially this is a proven medication, especially Punarnavadi Kashayam. Next, Chandraprabha Vati, also the same thing, which can rectify from the level of Jataragni and having proper anulomana of Apanavata, and as a Rasayana, this is very good. And Kledahara, it can remove the toxins from the kidney level. So that's why it is considered as the best Rasayana in Mutravaha Srotas. Next, especially this Niri KFT, a proven proprietary medicine, which commonly any Ayurvedic consultant cannot leave this product before writing this product. So it's a proven nephroprotective, having good role, especially in CKD and all. So overall diet, again, what we were discussing, the diet Patya and Apatya is based on the main primary disease, especially diabetes mellitus means, so Pramehahara diet should be followed. Hypertension, Raktachapahara diet should be followed. So the diet should be based on the primary disease. So overall, like restricting the salt, restricting the fluid intake and all, it is a general principle what it is adopted. So on an average, like seeing the output of an individual, we will have to plan for the fluid intake. There is a myth like we should drink only 500 ml or 800 ml and all. So later the person will suffer from dehydration and the person will go to the modern hospital for IV fluids and all. So that should not happen. So overall, seeing the output level, we will have to decide what should be the intake of fluid. For example, 1500 ml output is there, means 1500 ml input also should be there. It should be proportionate. Next slide, apatya. So especially excess protein overloading, junk food or high salt intake and all, alcohol and all, so better to avoid. Next slide. So overall, a normal lifestyle should be maintained. Avoid nephrotoxic. Simply going to a medical shop, consuming painkillers, especially we have this NSAID induced nephrotoxicity. So that's why simple consumption, simply just consuming painkillers or antibiotics without any proper prescription and all such things should be avoided. Stress factor overall can influence any disease, so that has to be balanced. Next. So conclusion. So as to address the primary disease. So second point, Ayurveda helps slow down the progression in early CKD. Definitely we can contribute to the modern society in addressing primary disease and as well as slowing down the progression. So for example, just creatinine now landed into 1.5, 1.8 mg per dl, 2 mg per dl and all. We can address that issue as early as possible. See that even after several years, it is constant there only. The progression of the disease can be slowed down by using our medication. At the same time, improving the quality of life also definitely. And one thing lastly, like integrative approach, this concept, modern people have to understand that, okay, in Ayurveda also there is a concept which can help in protecting the kidneys. The nephroprotective concept they should understand. And if they come forward in collaborating with an integrative approach, definitely we can do wonders in the modern society and can avoid dialysis and even renal transplantation. But I don't think modern people will agree with this issue. Okay, next slide. Thank you for patient listening. Thank you for Ayurveda One marketing organizers for giving me an opportunity. A small introduction about CKD presentation. Whatever I had a small information about the CKD, I could share with all of you. Thank you once again.
Participants, now the session is open for questions. So if you have any questions, you may please start typing it in chat box. So I can see we have a question. Can we give Dhanya Ka Jala for Pana to stage 4 or 5 CKD patients?
Yes, madam. It can be given. It's working like diuretic only, and work is also done about this dhanya jala, dhanya ka jala, dhanya jala can be used, madam. No issue.
Okay, there is another question. Very good presentation, sir. What can be done in Dahayukta Mutra where renal and kidney profile is normal? Tried all for UTI. Probably they didn't see any
So that can be
result, I guess. Huh?
that can be considered as Mutra Krichra only. So first we will have to understand the urinary pH, whether it is going more towards acidic level, so it's like less than 7 pH. So then more it should be alkalized. So then especially Ushira preparations, Chandanasava preparations, Sariva preparations and all can be administered. So especially this Mutra Krichra is of like lower urinary tract syndrome. So definitely we can address with Mutra Prasadaka type of medications, and Daha and all can be addressed.
Okay. Participants, any more questions? Way to use Needy plain and Needy KFT. Please
Yes,
tell us the
madam.
difference.
Right, even the ingredients wise and its percentage wise and all, more concentrated urinary tract issue, especially pyelonephritis, glomerulonephritis, and that glomerulonephritis leading to some functioning. So their Needy KFT is very, very specific.
Okay. We have another question by Abhishek Narayanan, who asks role of Basti in CKD, if as any particular combinations.
In general, like Mustadi Yapana Basti can be planned.
Okay. There's another question by Dr. Usha Holla, who asks, what does increased or decreased blood urea mean?
Increased blood urea, that means in the blood, if it is increased, either production is increased or expulsion is not properly happening. That means expulsion is inhibited. That's why it is increasing in the blood. Either production, especially urea, comes from the protein metabolism. So either there is more and more production of this metabolic waste product, or it is not properly expelled out through the kidney. So that's why there is a possibility of increased blood urea.
Okay. Is there any other option, sir, rather than going for dialysis in stage 5 CKD patients like Shodhana or Shamanaushadhi?
As we were discussing, madam, Shodhana to some extent may not be indicated, because the person when they come with 5 mg, 6 mg per DL creatinine and all, the person will be having severe anemia. So most of the time the patient may not be, though the disease is indicated, the patient may not be indicated. So rather we can plan for Matra Vasti. Simple, especially when we can plan for Punarnava, Gokshuradi Niruha plus GTG Anuvasana with very minimum dosage of Basti. That can be planned.
Okay, we have another question. So please explain what Panchakarma can be performed in the creatinine old patient. I mean, creatinine, I guess the patient is old.
Yes, old means only one thing, like the person is not indicated for Shodhana procedure. So then first, whether the patient is old or new, first the idea is how far the causative factors are addressed. So that we will have to understand, and then go for this type of protocol. So iron, especially the hemoglobin, has to be taken care. So there is no other option than going for erythropoietin hormone. And second one, especially the nephroprotective type of medications, for example, Shilajit Loha, such type of preparations can be added, especially Punarnava, Gokshuradi Kashayam can be added, or we can go for this Needy KFT can be practiced. So depending upon the risk factor, how far it is under control. So based on that, we can plan for the line of treatment.
Okay. What's the exclusion level of creatinine we can take? I mean, like,
Yes,
up
yes.
to what level?
Practically speaking, there in the modern science, they try with treating the causative factor up to 5 mg per DL. So up to that level, we have a scope in addressing the causative factor and going through the nephroprotective type of medications. Or if patient is indicated, we can go for Shodhana procedure also. If it crosses 5 mg per DL, better no more. We should try with any nephroprotective medications can be addressed, but better to take an opinion from the nephrologist.
Okay. Is there any role for Avapidaka Sneha in the treatment of CKD?
Mhm. No, madam.
No. Okay. How to treat increased urea in blood?
That's right, the same thing. Uh, Whether the person is having high protein intake, first we'll have to understand the liver function test. Is there is high protein level, especially serum protein level. If it crosses 8 grams per DL, then better to restrict the intake of protein. So then going through the hepatoprotective medications, we can see that the ongoing process of metabolism, protein metabolism, protein catabolism can be arrested there only. Then we can see that the level of creatine, the level of urea, the one which is coming in the blood, can be inhibited. If there is any pathology pertaining to the kidney, again due to CKD and all, again nephroprotective medications can be addressed.
Okay. Next, sir, you correlated Kaphaja Shotha for CKD. Instead of,
Hmm.
can we correlate with Mutragata? And can
Mutra
Shilajit be
Ghata,
used? Is it
yes.
safe in CKD?
Mutra Ghata is like vague term, madam. Because we have 13 varieties of Mutra Ghata, which one has to be correlated? Even there, when lower urinary tract issues are also there. So that's why rather than going through Mutra Ghata, I think especially while I was doing PG also, many our scholars had the same idea. Even the research work also was pointed out pertaining to Kaphaja Shotha, because Shotha is obvious in the patient. Patient is anemic, and there is pedal edema which is fitting in nature. So with understanding all these issues, one can correlate to that of Kaphaja Shotha than Mutra Ghata, which is very vague. Okay.
Okay. Can any other Panchakarma be used apart from Basti?
Basti one only, madam, because it is Adho Bhaga Hara treatment. Neither Vamana nor Virechana. Virechana, especially Gomutra Haritaki, is helpful, especially Nitya Virechana type of procedure. Even in Jalodhara also, we come across with Gomutra Haritaki Prayoga. Here also in Kaphaja Shotha, we will come across with Gomutra Haritaki Prayoga. So that can be used. And other Shotas and all, other especially Panchakarma treatments and all of not much beneficial in Kaphaja Shotha.
We have another question. At what period of time Sarvato Badra Rasa can be given to the patient, and in
No idea.
up to what
that we'll have
creatinine
to
levels? Okay.
that we'll have to apply and we'll have to see, madam.
Okay. What is the dose of Gomutra Haritaki?
That actually Gomutra Haritaki is coming in different presentations, madam. If it is like a tablet Haritaki and Gomutra, then 15 ml Gomutra plus 2 tablets. If it is coming like in Leha form, nowadays it is coming in Leha form also, 1 TSF in the morning, empty stomach.
Okay. We have another question. Electrolyte balance, especially sodium loss due to dilution, cause how can we address?
Sodium loss, if you understand whether it is mild or moderate or severe. Mild to moderate, our own Saindava is sufficient to manage. Or nowadays we are getting even soda mint also orally. If it is severe, especially if it crosses 120 MEQ, so definitely we will have to go for IV line only. There it goes towards Atyayika.
Mhm. Okay. Any more questions, participants? Okay. Uh, Dr. I guess this is what the questions are for today. Participants, I'm dropping all the links for registration, certificate registration, our WhatsApp channel, YouTube channel, and also the email ID to reach us out for any further questions. So with this, we have come to end of the session. So I would like to uh, extend my gratitude towards Dr. Gopal Krishna for so kindly and generally generous acceptance of our invitation to be our guest speaker today. So you just not only gave your time to us, doctor, but you gave your clarity with precision and depth of your knowledge towards management of
chronic kidney diseases through Ayurveda.
Thank you, madam. Thank you.
So I would also like to extend my thanks to our wonderful participants. Thank you for showing up, for engaging with such curiosity, and for being part of this growing community of Ayurvedic practitioners who refuse to stop learning. You are the reason these sessions exist. And last but not least, a heartfelt thanks to our sponsoring team, Ayur Central and Ayurveda One, for making this platform possible and for believing that authentic knowledge freely shared has the power to transform healthcare. For bulk orders or product inquiries, please reach out to us via the contact details shared in chat box, that is info@ayurveda1.co.in. We would love to hear from you. Do subscribe to our YouTube channel. Those who joined the session late or who had to leave the session in between, do not be disappointed because the session will be available on the YouTube. So the YouTube recording will be shared on WhatsApp channel. So you may also join our WhatsApp channel to uh, access the links for the recorded session. So the next insight session is just around the corner and you will not want to miss it. Until we meet next time, stay rooted in your practice, stay inspired in your purpose, and keep carrying Ayurveda forward with pride. It deserves thank you and good evening. And I can see Dr. Manohar telling the link is not opening. Sir, I would like to share my screen with you. Uh, I'm actually able to see the what do you call link. I will just show you, sir. You may please see the sharing the screen. So if you can see here, I'm just trying to access the same link that was shared to you through the chat box. So if possible, I would request you to, yeah, you can see I'm clicking on this link and um, you can see the link is open. So I would request you to kindly open and try to open it at the convenient time of yours, sir. So meanwhile, again extending my thanks to Dr. Gopala Krishna and all our participants. Until we meet next time, fresh Ayurveda and love Ayurveda. Thank you.
Thank you. Thank you, madam. Thank you once again.
Sir, with the dialysis, sir.
Madam. Hello.